Hello, this is going to be a presentation on asthma, COPD, spirometry, and FEN, all packaged into one. And this is an enlargement of a previous presentation which I had made in a summarized way of asthma 2021. I hope you find the presentation useful as it is designed on the NHS practice, and also it is very practical. Here you see me in a miniaturized way, and that's entirely acceptable to me. And also we'd be discussing the presentation in a more fuller way. So how does one describe asthma? Well, it's obviously an airflow reduction and limitation, but it is spontaneously reversible on its own or with treatment. And this is what distinguishes it from many other respiratory illnesses. It's caused mainly because of airways which have become extra sensitive to various triggers and allergens, and they respond effectively in the prescribed manner, in a set manner. This is also an inflammatory disease of a chronic nature of the lining of the airway. And so therefore, it starts from the pharynx and goes down to the alveoli, and possibly also affects the lung tissues. The presentation is based on international consensus in the region, global initiative of asthma, National Institute of Clinical Excellence, British Thoracic Society, and Scottish Intercollegiate Guidelines Network. So they've all put in their feedback as to what asthma is and what asthma should be treated as. And so these are the characteristics of asthma, and these are obviously well known to you anyway, but this is by way of a revision. It produces recurrent symptoms, and it is very variable. So sometimes it would happen in the morning, sometimes in the afternoon, sometimes with one trigger, sometimes with another. And the responsiveness would be variable. This is why it changes every now and then. And it is triggered by intrinsic triggers, such as those related to hormones and other chemicals which are circulating in the body, including adrenaline and other transmitters. It is more commonly related to extrinsic triggers, and we'll discuss about these in a minute. Sometimes it seems like an allergic-based response with no specific allergen discovered. And then, of course, it's an autoimmune kind of a disorder with no known trigger. Because of its variability, and because it can also happen with minimal symptoms, most of the elderly people remain underdiagnosed and therefore undertreated. This is the story in the UK. And so the Office of the National Statistics and other reliable research papers suggest that the incidence is increasing, and this is due to more pollution, environmental damage, worsening of carbon dioxide, reduction of oxygen, and so on. And close to about 110 million people worldwide are affected, and of these, 5 million are in the UK. Close to 2 million children are affected, and this is 20%. And 1 in 7 adults has a 1.256% chance of getting an asthma. And so In analysis, 15% of children and 7% of adults in the UK have asthma diagnosed. If one parent has a family history of asthma, then the child has 33% chance. And if both parents have it, then the child has 66% chance of developing childhood asthma. Approximately 850 million pounds per year are spent on asthma treatment, and 18 million working days are lost. So this has a huge economic implication. And this is why the NHS does so much to control the symptoms so that people can become more reliable with their careers and with their duties. The peaks of asthma are common in three phases: when a child is less than 2, when the child is between 5 and 6, when the child is in the mid-teens, and also in adults between 40 and 50. But that's not to say that asthma does not occur out with these peaks. Surprisingly, it's more common with affluents, and also observational findings suggest that it is more prevalent in people who live with central heatings in the house, who have a small house, a small family, better living, and a better sense of hygiene. So such people have more asthma. And it is possible that the less fortunate people are exposed to triggers, get adjusted, and become responsive and begin to ignore asthma, or it doesn't affect them. Scientists do not understand why. Only 15% cases are of a late onset. And if someone beyond the age of 66 has asthma, then one would be suspecting it to have been caused by a sinister disorder. What are the extrinsic triggers which can precipitate asthma and set the wheels in motion to produce full-blown symptoms and signs? I regard this as this mnemonic, IAEECHARD. And this is infection, atmospheric pollution such as nitrous oxide and nitrogen, exercise between 6 to 15 minutes, and then the effect of the exercise lasts for 30 to 40 minutes in producing asthma. In healthy people, exercise relates to shortness of breath, which subsides very quickly. Emotions, chemicals such as isocyanate and other chemicals in the water and in the environment. And then we have chemicals we have already discussed. And we have household allergens, particularly detergents, sprays, air fresheners, and also carpet mites. Then we have animal products such as cat dander and mammalian hair, such as pets in the house, dogs and other animals. Then you would have gastroesophageal reflux disorder causing a trigger-based asthma. And there are certain drugs which, if in use, can also produce asthma-like symptoms, such as beta blockers, NSAID, such as ibuprofen, naproxen, Voltaren, and methotrexate, used for a variety of dermatological and autoimmune disorders. So these are the well-known extrinsic triggers. What happens when someone has asthma? I've already mentioned that the lung linings are oversensitized, they are extra sensitive. So there would be histological presence of eosinophils, mast cells, and allergic mediators such as cysteine leukotrienes, which sustain and maintain inflammation and produce the resultant bronchospasms, bronchoconstrictions. There is a release also and presence histologically of histamine, which is an allergic producing substance, thromboxane, which is an anti-clotting substance which produces clots in excess, leukotrienes, cytokines, and platelet activating factors also combine. All of these allergens are less than 15 microns, so they are very small in size, and therefore, once they are caused by some agent, then the depths of the alveoli are reached, and the lung becomes sensitive on the whole. So the first issue was sensitive, excessively sensitive lung lining. The second aspect of the pathology is chronic inflammatory response. And this is characterized by bronchiolar smooth muscle constriction. There is also excess vascular permeability leading to mucus plugging, and constriction of the smooth muscles and plugging by mucus elements cause mechanical narrowing. And one would remember that if you have a flow through a tube, whatever the tube is, and in this case, they are bronchial tubes and alveolar tubes, and the flow is proportional to fourth power of the radius of the tube, which means that if the radius of the tube is halved, the flow reduces to 1/16. So it means if the pre-terminal bronchiole is, say, 4 millimeter in diameter, then the flow is reduced to 1/16 because it's fourth time. The inflammation further aggravates hyperresponsiveness of the lung linings. So lung lining is excessively sensitive, and inflammation in the region and the chemical mediators further make it more inflamed. So it is acute on chronic inflammation sometimes, or chronic on chronic inflammation. If the asthma attack persists without reversal, then eventually the smooth muscles will hypertrophy. And in doing so, they will produce irreversible narrowing. And it is common observation to see that most asthmatics who do not have any symptoms will continue to have prevailing inflammation. So even in an asymptomatic state, there is chronic inflammation present, which can worsen. So please remember that the inflammation does not cause any real symptoms except for receptor irritation causing cough. It's the mechanical obstruction which produces the symptoms of asthma. So what are the symptoms of asthma? Shortness of breath, and this is known by a variety of names: bronchospasm, dyspnea, and it is usually worse at nights and is with also exercise. So a small amount of exercise will cause a durable shortness of breath. It is also characterized by audible wheeze, and it is the wheeze and shortness of breath which determine the severity of asthma. There is a condition called cough variant asthma, and this is usually produced in people who become hyperresponsive or allergic to triggers, mainly ACE inhibitors. So they develop not shortness of breath, but cough, usually at night. With severe asthma, the chest muscles become exhausted. A person is inhaling rapidly, but to a shorter depth. So therefore, is recycling the air, and therefore oxygen is going into the dead space and coming out mostly and doesn't go deeper into the lung tissue. So there is resultant cyanosis. And because of carbon dioxide and lack of oxygen and stress and exhaustion and anxiety, there would be tachycardia. The tightness of the muscles of respiration would produce tightness in the chest and therefore some chest pain. There is a false notion that asthma results in weight loss. It doesn't. It doesn't produce lymphadenopathy because it's not a viral infection. It does not produce clubbing because it's not a desaturating disease. And it does not produce beta symptoms of malignancy. So how does one diagnose asthma? You give a peak flow meter to the patient and teach them how to do peak flows, and it would show clearly 15 degrees, 15% variation. So one morning it would be 400 liters. Second morning at the same time, it would be 350. Then it will be 410. So there's no fixed reading. It's variable by 15%. Spirometry will show presence of obstruction, which can be determined by simple formula of FEV1 divided by FVC, which is less than 70%. And we'll come to that in detail when we are talking about spirometry and related matters. If you do reversibility test with short-acting beta agonist, such as salbutamol, then after giving salbutamol, the FEV1 or FEV1 divided by FVC improves by 12%, and that's reflected in a beta volume of air expiration of 200 mils. And if someone registers 400 mil after the challenge of SABA, then he is definitely got asthma. Alternatively, if someone is given a 2-week trial of oral steroids, such as in an adult, 30 milligrams of prednisolone daily for 10 days or 2 weeks, then there is 15% improvement in the spirometry FEV1 or FEV1 over FVC findings. Cough variant asthma, I've already described, is a feature which affects 10 to 15% of asthmatics. When someone has severe asthma, then causes exhaustion, cyanosis, and tachycardia. The false belief is that asthma will cause a cough. That is not true. 30% of the children, instead of having visible bronchi, will have occasional wheeze that mothers can hear externally. The history response to treatment with SABA and diagnosis made by FEN confirm the diagnosis in children where spirometry is not easy to perform. We'll talk about FEN a little while later in the same program and presentation. Asthma is generally worse at nights and lasts for a longer time with physical exercise. It's the wheeze and the shortness of breath which determine severity, not the cough. And one should undertake basic assessment in asthma before confirming the diagnosis to make sure that it doesn't have a neoplastic or a fibrotic element. So we differentiate asthma from COPD, and we'll deal with this in a little while. It can also be confused with left ventricular failure, heart failure in the older patients, and echo will show left ventricular end diastolic pressure to be less than 50%, amongst other clinical features. It can be confused with pulmonary embolism in view of the chest pains caused by the exhaustion and tightness of the respiratory muscles of inspiration. It can produce symptoms relating to vocal cord dysfunctions because of the chronic inflammation, voice changes, and loss of voice. Anxiety and hyperventilation go hand in hand, and sometimes they appear to mimic asthma. Viral infections such as flu can mimic asthma, and so can COVID-19 infection. So how does one investigate asthma? So from the symptoms of being worse at night and lasting for a longer time with exercises, wheeze and shortness of breath, which are inconsistent and very variable, and their severity will be able to lead to the diagnosis of asthma. Cough, which responds to salbutamol, is not asthma, is asthma. Exhaustion, cyanosis, and tachycardia would be features of asthma. And so we would, in the end, attempt to do a spirometry, which will lead to the diagnosis in half of asthma. Then we do a reversibility test to confirm that it is a reversible narrowing and reversible obstruction, which from its variability will be diagnosed as asthma and not COPD. And particularly when you undertake the FEN test, which is fractional expiratory nitrous oxide test, you will get a reading of 40 parts per billion, and that will be confirming the diagnosis of asthma. Peak flow recording done by patients themselves in a diary will show low value, but it is variable. How does one manage asthma? In all stages, whatever stage you put asthma at, you should do a lateral flow test to exclude COVID-19 in this environment and in this climate. The aims of management are prescribed by the Swindon statement that nobody should be allowed to have loss of sports, loss of career, loss of daily functioning, and should have full daytime control of asthma and nighttime control of asthma, and should be able to deal with common triggers such as hay fever, such as temperature changes, and also the pollution of the air in the local area. There should be control of symptoms and control of exacerbations as well. Asthma, as we all know, is characterized by periodic exacerbation. So this should be prevented, which should be a policy of management. There should be minimal lifestyle disturbance. So return to work, to school, engaging with sports, hobbies, careers, that should be the aim. However, 40% of the asthmatics say, despite the given treatment, that their symptoms affect their lifestyle. Following the NICE, SIGN, and BTS guidelines, we should adopt a stepwise approach in managing asthma. So the first step under the BTS SIGN guidelines, which is approved by NICE and is peer practice, step 1 asthma is when there is mild intermittent asthma. So if you prescribe short-acting beta agonist, such as salbutamol, whenever needed, then it relieves the attack of asthma. And so wise children take a puff before their daily exercise, such as in the gym or during their physical exercise sessions of the school. So one could use salbutamol, terbutaline, or nowadays montelukast. And therefore, these are called relievers. So they relieve the produced symptoms. And of course, as it is in the nature of the stimulant effect of short-acting beta agonists, overuse can cause tachycardia, tremors, and low potassium. Step 2 asthma is when someone is needing short-acting beta agonists daily. And if that is happening, then it's 7 times a week or thereabouts. So one should prescribe inhaled corticosteroid, which now is called preventer. SABA is the reliever, and ICS, inhaled corticosteroid, is a preventer. And this is almost always beclomethasone, and the dose ranges from 200 to 800 microgram per day. And the starting dose should be related to the severity. And for most grown-ups, it is 400 microgram per day. That means 200 micrograms in the morning and 200 micrograms in the evening. Correspondingly, the dose is reduced in children. And the common brands are Qvar, beclomethasone, beclomethasone, fluticasone, and fluticasone is twice potent, so the dose should be reduced. The use of the printer can prevent remodeling. Remodeling is the term used when long-term damage into the bronchial tubes occurs from uncontrolled or poorly treated asthma. Then the smooth muscles hypertrophy and produce narrowing, and that is remodeling. And therefore, this is unlikely to improve with further treatment. So early, prompt, and regular use of the preventer can prevent remodeling and future respiratory damage. Overuse, on the other hand, of inhaled corticosteroid as preventer can produce oral thrush, and that is prevented by rinsing of the mouth often and making hygienic care of the inhaler. The steroid in it as such can produce cataract, and sometimes it can lead to adrenal suppression as well. It can affect growth reduction in children, and in pregnancy, it can produce intrauterine growth retardation. But this is debatable, not proven, but observed. Step 3. So in step 1, it is just salbutamol. Step 2, it is salbutamol when needed and beclomethasone when to use on a daily regular basis to prevent. So beyond that, if the patient continues to suffer, despite the step 1, step 2 treatment, which are both continuing, then you should add LABA, long-acting beta agonist, and that is salmeterol, oxys, formoterol, and aformoterol agents. So these are LABAs are added to ICS, inhaled corticosteroid, and this is much more effective than at this stage doubling the dose of inhaled corticosteroid. Remember that the common dose is 400 micrograms per day, So one can raise it to 800 micrograms per day as well to control step 3, but it is far better to continue with 400 micrograms of ICS and to add LABA. So if there is poor response, even then, so you've continued with step 2 meds, you have added LABA, and still there is poor response, then at this stage, increase the inhaled corticosteroids from 400 micrograms per day to 800 micrograms per day, which means 400 micrograms in the morning and 400 micrograms in the evening. If the patient is still symptomatic, that means has shortness of breath, then add slow release theophylline or leukotriene receptor antagonist. The slow release theophylline are phyllocontin, and this is anti-inflammatory. And leukotriene receptor antagonist would be montelukast. Side effect of these treatments, which means theophylline and montelukast, and increasing the inhaled corticosteroid to 800, would lead to GI tract disturbances, as NSAID and prednisolone can affect the stomach and the small bowel linings. It can also produce arrhythmia, cardiac arrhythmia. It causes reduced potassium, and sometimes it can lead on to fits as well. So what happens when a person who has got asthma goes beyond step 3? Then you will continue with step 3 medications, which are salbutamol if needed, ICS, which is beclomethasone, at full strength, that is 800 micrograms per day, and you have added LABA to it as well. And so now you will increase inhaled corticosteroids beyond 800 micrograms, and in adults it would be 2000 micrograms, and in children it can go up to 800 micrograms. And so at this stage, you can add the fourth drug, which is leukotriene receptor antagonist, which is montelukast, or oral salbutamol, which is short-acting beta agonist. That would be to control conditions of strep 4. Leukotriene receptor antagonist is montelukast, which is licensed for over 2 years. Zephyr-Lucast is licensed for over 12 years, and these reduce exacerbation, and the patient improves by 5 to 8% on spirometry. And it should be continued with symptomatic improvement until the patient is much better, has lost the trigger-based exacerbation, and then one can reduce and step back again to following the step 3 treatment. Side effects of montelukast will be GI tract problems, headaches, rash, and Churg-Strauss syndrome, which is a kind of vasculitis where it causes thickening and swelling of the blood vessels inside the organs, producing various organomegaly and organ-based disease. Step 5 is like status asthmaticus. A patient is unable to complete a sentence and is constantly breathless. You still continue step 4 medications as before, as we've just discussed, and you start with oral steroid. So the oral steroid would probably be, for an adult, prednisolone 30 milligrams or 40 milligrams per day. Since it's given as 5 milligram tablets, you give 8 tablets stat once a day as 40 milligram of prednisolone per day, and you keep giving it for around 10 days, some say 2 weeks. But during this time, and this is pulse treatment in a bolus It is given for 8 days, 10 days, 15 days. You monitor blood pressure, which is likely to rise. You monitor sugar through fasting blood sugar. You monitor osteoporosis from doing FRAX assessment or from doing the scans, uh, DEXA scan, dual energy X-ray absorptiometry. And so not all patients would need DEXA scan, but you monitor calcium and phosphate and vitamin D and parathormone. And if you feel a disturbance, then obviously you should treat that. But at this stage of step 5, you refer the patient from primary care to the secondary care to the respiratory consultant, as the patient would be in need of regular nebulizing and also regular steroid treatment and further investigations of triggers which can be resolved. So when you have dealt with a lesser grade of asthma, step 1, step 2, step 3, step 4, then you do your best to avoid precipitants and trigger factors. So that would mean smoking cessation. And for this, non-nicotine based cigarette smoking also apply. Vaping will be just as bad for asthma as nicotine cigarette smoking. And so this should be cessated as quickly as possible. And it's no answer to put patients on replacement of nicotine pipe patches because it will still affect the asthma. You eliminate pets. The commonest trigger in the UK is cat dander, that is the skin shed by the cats. The impact of it is such, since many houses in the UK are carpeted, if you remove a cat, the effect of the cat dander trigger disappears after 6 months. So it is better to eliminate this trigger at an early part of asthma development. Obesity adds further to difficulty with respiration. Both inspiration and expiration can trigger and produce sleep apnea and contribute to comorbidities such as heart disease, additional respiratory disease, hypertension, diabetes, and so on. We should encourage, as the asthma progresses, to arrange for respiratory rehabilitation, and that would allow the experts to build up on their respiratory volumes, which can be increased. Triggers should be removed, such as carpet mites. It is surprising to see figures. Mites are resident in the carpet. They are inert, they are microscopic, and they live on human skin shed from time to time. 1 square meter, that means 1 meter long, 1 meter broad, making it into a square, will have 1.6 million mites. That is the extent of the size of the mites. So carpet mites cannot be sucked away with a vacuum cleaner. So periodically, the carpet should be washed by a carpet shampooer or removed and replaced by wood panels. Elimination of triggers such as room fresheners, perfumes, and some other chemicals which are used on the surfaces of the kitchen and nowadays increasingly to prevent COVID. These can trigger and sustain asthma. So if someone has life-threatening episode of attack, can't complete a sentence, is unrelieved, lying down, sitting up, is always uncomfortable, may have cyanosis, a person who has that degree of asthma and is cyanosed this is a kind of a pre-terminal event, and one should immediately provide oxygen. Such patients will have bradycardia and a silent chest with hypotension. They themselves make poor respiratory effort because they are exhausted, and their peak flow is less than 33%, and this is maximum. So you offer them inhaled oxygen fast, nebulized short-acting beta agonist or leukotriene receptor antagonist as nebulizers. And the nebulizing solutions would be in salbutamol 5 milligram nebules or Atrovent nebules 500 micrograms. And this dose should be reduced by half in children. Pulse steroid treatment of prednisolone that we have earlier discussed should be given for 5 to 10 days as a rescue medication. If there is danger or presence of infection, bacterial infection, antibiotics should be given, to which patients is non-allergic. Now, in order to facilitate compliance, since patients are less likely to have a reliever, a long-acting beta agonist, an inhaled corticosteroid, and an anti-allergic substance separately, for improvement of compliance, combined inhalers are now available. So LABA and steroid Symbicort. For Motorol and beclomethasone is called Foster in 2 strengths. For Metrol and budesonide, it suits some people, is also Symbicort 2 strengths. It's also available as Foster. For Metrol and fluticasone, which is a steroid, is Flutiform. Salmeterol and fluticasone is Seretide Acuvela. So there are many brands. Patients get used to it. And a clever doctor would be able to see these products and say, don't use your blue inhaler, use your purple inhaler twice a day, or use your green inhaler twice a day. So that is why you need to familiarize yourself with the dummy combined asthma inhalers. So what is spirometry? So spirometry is done to check how fast and how effectively a person can exhale air. Remember, the asthma is not an inspiratory disease, it is an expiratory disease. So forcing out air is malfunctioning. Taking air in is not malfunctioning. So as you remember, the total lung capacity is inspiration of air until the dead space is filled, until the air goes to the lung, and then making an extra effort to force air in to a large extent. And so when you have forced air in at that stage, there was still some air in the end pockets of the alveoli. So you have added to that. So the end part of the lung, which traps and keeps the air, is the residual volume. And above that is lung capacity. So if you force air out, that means first take a big breath in as much as you can, and then force the air out until you can't expel any further air. And beyond that is a small amount of residual volume, which is not under your control. So that is testing for your expiration. So this measurement is done by large spirometers fixed to the wall, becoming like an office table, now available as portable handheld devices. And all you've got to do is to feed in some characteristics of the patient, such as gender, such as age, such as height, no need for weight, no need for other things. And then the memory of the system, memory of the handheld device will show what is expected by way of the number from breathing out in a man or in a woman or in a child of a given age and also height. So this is the predictable number. And so what the patient has produced is adjusted against the predictable number, and percentage can be worked out that this person is below the predicted or above the predicted, and if so, how much. Another device recently introduced is FENO, fractional expired nitric oxide level. Very easy to perform, and it measures nitric oxide in parts per billion. It's an expensive little gadget, but it confirms presence of asthma if the reading is in excess of 40 parts per billion. So if you do the test, you ask a patient who has been well explained to stand up, to hold the spirometer in his hand when it is being fed with information such as gender, age, height. Then the patient sort of takes a very big breath in and forces air out until he has no more air to take out. And the device then measures how much air the person has forced out in 1 second and how much, which is FEV1, forced expiratory volume in 1 second, and how much air has the patient put out in total, right to the very end, which is forced vital capacity. And of course, as I've explained earlier, that when he has forced out all of the air that was possible, there is still some residual air in. So one can calculate what the FEV1 is, that the percentage of air expelled out of the total in the first second. And that is usually 70% of the volume. So 70% or so of all the air that the patient throws out of the body comes out in the first second, 1 second. So we can calculate from the FEV1 to forced vital capacity as to what the position is, and it can show up in numbers as well as in graphs. So once again, take a big breath in as much as possible, maximal inspiration, and expire forcibly to the end, which means you've only got residual volume left. As one breathing test. You do a total of 3 such tests while the patient is standing. Within a minute or so, you do the next one and then the next one. And the device, the spirometer, registers all 3. If each reading is within 5% of the other, they are acceptable. Otherwise, if 2 are within 5%, the device measures just these 2 and the outlying one is ignored. So you take the average of the 3 readings of FEV1 and FVC. Remember that FEV1 is forced expiratory volume in 1 second. And forced vital capacity is right to the end until you have been left only with residual volume. So if the handheld device's computer will calculate the first second exhaled sort of with FEV1 divided by FVC, and it will show up whether 70% of the air has been exhaled or not. More than 70% is normal, less than 70% is abnormal, and that means the person has asthma. So looking at it in actual measurements, there is a female who is 33 years of age, whose height is 165 centimeter. And when she did her measurement spirometry, we concentrate at this stage only on FEV1. So the FEV1 that she produced was 3.20 liters. So in 1 second, she had exhaled 3.20 liters. The handheld device computer spirometry will say such a woman should have inhaled 3.03 liters. But she has exhaled more. She has exhaled 3.20, whilst 3.03 was expected as average. So therefore, she has exhaled 105%. And that means her FEV1 was quite good. Now, we were talking about FEV1 alone. If in a patient, FEV1 measurement is less than 80%, so predicted in a hypothetical patient with whom we have got the measurements of gender, height, and age, and if the FEV1 measurement is less than 80% predicted, and if FEV1 divided by FVC is less than 70%, then this is COPD. Because FEV1 is reduced and FEV1 by FVC is less than 70. So when you are dealing with COPD, we categorize these into 3 kinds of COPDs: mild, moderate, and severe. Mild COPD is FEV1, which is greater than 50% and less than 80%. Moderate is when it is greater than 30%, but less than 50%. So we can step down there. Severe is when FEV1 is less than 30%. So FEV1 more than 50% is mild. FEV1 more than 30%, but less than that is moderate. FEV1 less than 30% is severe. So giving an example again, and we are now talking about either asthma or COPD. Female, 33, 165 centimeters. Her FEV1 is 1.8 liters, and predicted FEV1 was 58%. So it is much less. Her FVC was 3.5, and FVC predicted was 58%. So here, the FVC and FEV1 are both reduced, but disproportionately. Remember that FEV1 is about 70% of FVC. And here, it is not so. So therefore, if in this case, the FVC and FEV1 are both reduced, but are disproportionately reduced. So this is likely to be COPD. But in this scenario, this is a male, 49 years, 165 centimeter height. And his FEV1 is 1.80. And predicted FEV1 was 4.02 liters. So his FEV1 is only 45%. So FEV1 is 45%. And his FVC was found to be 2 liters, and FVC predictors was 4.9 liters or 40%. So you can see the FEV1 is 45% of 40% FVC. So they are both reduced proportionately. So if FEV1 is reduced in proportion to FVC, then this is likely to be a restrictive disease. So unless I have confused you, asthma is airflow obstruction when there is reduced FEV1. Asthma obstruction is FEV1 by FVC is if it is less than 70%. So if it is more than 70%, patient does not have asthma. So if FEV1 divided by FVC is less than 70%, then that is asthma. A restrictive disease is when there is reduced FEV1 and reduced FVC, but FEV1 by FVC ratio is normal or high. So therefore, from this calculation, we know that if someone has normal relationship between FEV1 and FVC, but both counts are low, it is restrictive disease. A restrictive disease is an important serious illness such as fibrosis or a constitutional disease such as tuberculosis, pneumoconiosis, or worse still, a mesothelioma. If there is severe airflow limitation and reduced FVC, then obviously this will also show likelihood of COPD or restrictive disease. When numbers are vague and don't fit into between diagnosis of COPD and restrictive disease, rely on clinical judgment. So if there are asthma-like readings, but COPD-like symptoms, ask for smoking history of recurrent infections, of productive cough, which will point to more towards COPD. So easy ones can be diagnosed as asthma and COPD on the basis of spirometry and FeNO, but difficult ones should be taking into consideration clinical aspects to differentiate between asthma and COPD, and X-ray and histology will determine restrictive disease and MRI scan. So we look at COPD, summary of analysis and of symptoms as we have just discussed. There is airflow limitation, that means obstruction. There is pulmonary hyperinflation. So air is trapped in, some say in the old days used to be called emphysema. There is problem of gas exchange. The alveolar tissue is unable to exchange carbon dioxide of the blood with oxygen in the air. And there is also pulmonary hypertension. So there could be gas exchange defects, could be pulmonary hypertension, cough, sputum, progressive dyspnea, ankle swelling. So these would be due to restrictive disease, cardiac failure, or pulmonary disorders. FeNO. This is a new investigation, and we are nearly finished with my presentation. So with FeNO, it measures fractional exhaled nitric oxide as parts per billion, child-friendly, unlike the spirometer where a child is expected to go down to maximum expiration as total vital capacity, and many children under the age of 10 do not do it properly. But FENO is a game for them. It's easy to use. It When you have a handheld device FENO, it is battery operated. So if the batteries go weak, you just change it. There's no hassle of putting it into a charger and therefore not be finding yourself ready when the child has actually come in. It's portable. And one of the disadvantages is that the nitric oxide, which is part of the reserve chamber with which it compares the um, exhaled nitric oxide, needs to be charged up after so many tests, like 300 tests or 400 tests. And therefore you need to bottle charge it and then calibrate it properly. So if it is ready, I you explain to the child that this is where you blow, this is where you look, and as you blow air out, a ball will rise in a chamber that the child can see, and the child needs to blow out enough to keep it in the middle. If it blows too hard, it goes to the top. If it blows too little, it comes down. So the child understands it easily. Child of 5, child of 6 can easily do that. So he blows as hard as it would as would to keep the plastic ball in the middle. So it is very simple like this. And it is finished in about half a minute or thereabouts. But when it reaches a certain recognition, it just stops. There's a beep, and you congratulate the child, and one off checking is enough. And so, if the reading which comes instantly is more than 40 parts per billion of nitric oxide, then you can literally diagnose the child with asthma. So this is now becoming the first line test of a child. And so if there is an older child in whom you're going to do spirometry as well, then the best is to do FENO first, which is very easy. And then you can compare the differences and explain the differences of spirometry to the child, and the child would be able to do that. So this is the end of my presentation, and I hope that I've not confused you with the numbers and that you would be able to see the presentation for any further clarification yourself, because the PowerPoint slides will stay. And I'm pretty sure that you will be able to apply the learned knowledge by way of revision into your clinical practice. I wish you good luck.